Welcome back to Creating Dementia Solutions. Richard Pyatt here. This is a Miles for Memories program, and we invite you to follow us on the Miles for Memories Facebook page so you know when these episodes come available. Creating Dementia Solutions focuses on the mission of Miles for Memories and information you can use as it relates to dementia and prevention and more information. If you've attended the research updates for Miles for Memories, you'll know Dr. Graham Atkin from Michigan State University. You'll certainly recognize him. He's back with us on the program today, along with Izzy Brown and Reba Kortik, who are medical research students at Michigan State. Welcome, everybody.
Hello, thanks for having us.
Boy, it's great when we have such a big group to talk with on the program today. In fact, we intend to have a special double episode today, so 30 minutes talking about a number of things as it relates to dementia and research. So I guess we'll start, Dr. Atkin, with the notion that everybody's sort of focused on the idea of funding and where things stand and concerns about all of that. Can you give us a big picture of where we are?
Sure. The big picture is, in a word, turmoil. There's a lot of confusion, a lot of concern among researchers and lay folks about what is happening to research, what does the future of research look like, particularly around conditions like Alzheimer's, where we so desperately need progress. Mm-hmm. And I will say that the facts I'm about to state are accurate as of the airing of this episode, but things are very much in flux.
Sure.
So we're expecting some changes. There was just some progress yesterday in the Senate, potentially adjusting some of the cuts that have been made. The big picture is that funding has been changed across the board. So we'll start with where a lot of ideas begin, which is the National Science Foundation, which tends to be earlier research, so sort of more basic research stuff, but helping us put some pieces in play. A lot of that funding has been frozen, and they're not issuing new grants. Now, these grants are particularly important for early stage researchers. Later stage researchers might have additional funding that they can rely on, sort of equipment that they've already purchased, things like that, to keep going. Early stage researchers, you might only have one grant, and now that grant is gone. And so how are you supposed to keep your lab going? I apologize for stating something so obvious, but I think it's important to talk about that research does not function like a vending machine. You can't just put money in, push a button, and expect data to come out. It takes years. It takes many people. It takes a lot of effort. And so interrupting funding now will have effects for years on the outcome of this research. When we move over to the NIH, we're looking at 14 out of the 35 major Alzheimer's disease research centers in this country. 14 of those 35 have had their funding paused. Now, that pause is important because when you get NIH funding, you have to lay out a timeline by which you will spend that money, and you're planning. It's like planning out a small business. You're hiring people, you're getting equipment, you're getting mice or whatever it is that you're going to use for your experiments. You're planning all of that out. So to suddenly have that funding paused means that you may need to have you may need to fire folks. You may need to lay folks off. And that delays the return of the research. For PhD students who are up-and-coming researchers, their work can be interrupted, and now it's delaying the onset of their career and making it tough. PhD students and the next step up, which are called postdoctoral researchers, are not paid particularly well, and so they're doing life planning and saying, am I going to stay in research with this funding pause? They might leave and go to some other career, and now we've lost that capital. So it is a time with tremendous consequences, especially for diseases like Alzheimer's, where the studies take so many years. And that's because humans are complicated. A great example of this is actually from the cancer world with laryngeal cancer. So historically, the survival rates for laryngeal cancer were around 50 to 60%. After some studies that took between 10 and 15 years, the University of Michigan, that survival rate is now in the high 80s, low 90s. But had there been an interruption at any point during those years, we'd still be at 50 to 60%. There have been interruptions into funding for studying things like brain cancer, studying dementia, studying how the brain works, and it has created chaos. Researchers not sure if they can continue, not sure if they can bring staff on, retain their staff. They're changing their research priorities to try to think, what can I best get funded, and that's also affecting where science can go. It is a scary time.
Just to be clear, this kind of research is mostly funded by the government. Is that accurate?
Yes. So I would say it's a combination of funding through, for example, with Alzheimer's disease, through the NIH, but particularly the National Institutes on Aging, the NIA, which is the sort of a subunit of the NIH that really focuses on things like Alzheimer's dementia. Some labs will get funding from other agencies. This could be a private donor. This could be a foundation that contributes to this.
Sure.
But the majority of the funding is going to come from the NIH. The majority of funding for training scientists comes from the NIH. The majority of money for training doctors, for example, comes through the government. And so it is the effects of any funding or interruption or reduction. The NIH, is facing a 20% cut. That might go even bigger. The NSF is facing potentially a 40% cut. This will mean fewer scientists and doctors and fewer advances. Private industry may set up, but that brings with it another set of complications.
So you imagine what I was just about to ask. Will the private sector somehow step up?
Maybe. The private sector, and no disrespect to the private sector, has a drive to do things that are going to be profitable. And there are some avenues of research that will not be profitable. They, for example, are looking at drugs or developments for which there is no profit margin, things that are off the label, things that are not going to turn into a bottom line. And so their interest probably will be lower, right? Certainly we're in a bit of a pickle already in that human studies, so large human studies, almost require private capital because they are so big and cost so much. So moving further down that, I think we'll see a lot more influence of the bottom line into what gets studied and how it gets studied.
Even hospital systems or universities that might already be involved in the research process, would they step up somehow? Or is that still a profit question?
I think it's still, it's both. It's their ability to step up. A lot of universities receive NIH funding, and that's where a lot of their money comes from, to be able to do the things that they are doing. And likewise with hospitals, there is a bottom line that has to be, they got to keep the lights on, right? They got to keep all the machines running. So it's a tough situation. Now, I don't want to discredit the concern that led to these funding pauses and funding scrutiny. You've heard me speak out here in Battle Creek, and I'm sure folks can access the video, in Alzheimer's disease in particular. And neuroscience, in the last 18 months or so, there have been some really unpleasant facts that have come to light about people who did not have the best intention in their research, were deliberately misleading people for the advancement of their career and their own research funding. We know about those now. We can begin addressing those shortcomings. But my risk is that we're saying, the few bad apples have spoiled the whole bunch. I don't think that's true. But if we pause and say, we got to check out every apple now, some of those apples are not going to make it through the process of that scrutiny and that all that time that's lost. It is a tough time for research.
And that's by virtue of either way, I suppose. They won't rise to the occasion somehow in the scrutiny, or they won't want to. They'll say, I'm out.
Or they just can't wait that long, right? They can't wait for there are some of these Alzheimer's disease centers that were counting on 5-year funding. They had a 5-year plan to spend this money, and now that's on pause. And it's like, if we're not going to get that money, we need to change that 5-year plan. So now that 5-year plan is lost. It is a tough thing. I do think there's increased scrutiny in publishing. There's increased scrutiny of primary data and all these sorts of things. Certainly the industry has, the whole field of neuroscience has kind of a black eye now because of these, malefactors, but we've got to keep stuff going. Time lost is a little delay now is a lot of delay later.
Is there a chance we're overreacting, that it really won't eventuate in terms of the research funding the way we are seeing here in the onset?
I mean, not to get political, but these days it's hard to know. Everything is up. It feels like everything is up in the air, and we don't know, are things going to change on a dime? So many things have changed on a dime recently. My hope is that the funding cuts will not be as bad. People will find ways to make stuff work, but at the very least, it is causing a lot of anxiety. It's causing people to change their hiring practices. There are already people who've been laid off as a result of this. Grants that have been abandoned, grants that have been paused. And some of that, too, is folks are getting caught up in kind of ideological filters. So the government has put out a list of terms that if your grant application includes those terms, it's going to get flagged for additional scrutiny. In Alzheimer's disease, we know that there is a difference between the number of women who get Alzheimer's and the number of men who get Alzheimer's. We don't know why. That's a thing we want to study. It may give us clues.
Yeah.
But any grant that mentions women or females or sex is going to get flagged for additional scrutiny and may not get funded. So that limits our ability to study these things. You hope that after that additional scrutiny, they see, yes, this is valuable, what have you. But all that time lost can affect the ability of these institutions to do the research. It is tough.
One of the other things you mentioned is that this may affect the career path for folks like the folks who are with us today.
Yes.
How so?
Well, do my colleagues want to weigh in on that?
Yeah, the recent passing of the Big Beautiful Bill included limits on student loans. I think for medical students, the new limit is like $200,000, which is admittedly a lot of money. However, the total amount of student loans that I will be taking out is greater than that, and that's common for many medical students to require more than $200,000 in loans, especially if we can't work a job at the same time as going to medical school.
Sure.
Like medical school is essentially our job for 4 years. So those limits are really scary, especially for people in undergrad who would like to go to medical school, but with those loan limits, that might not be an option for them.
So those loan limits might mean you'll get 200, maybe you won't, if you're competing with others like you, I assume, right?
Well, and the alternative, so those are for what are called grad plus loans through the government. The alternative is to go to private loans that may have interest rates that are exorbitant or
Expensive.
questionable practices or what have you. But I think it is going to have an effect on who can go to medical school, and that influences who you can see when you go to a doctor's office.
So Izzy, does this give you pause at all?
I really think that this will impact the type of people that are able to come into medical school. And it's not even true just for medical school, but I know for like PAs and NP programs, they're also setting loan limits as well. So they're not just setting the tone for who's going to be your doctor, they're setting the tone for who's going to be your provider. And that can also differentiate.
Sure. So Reba, how does this make you feel? What are you thinking about as this is the path you planned, right?
Yes.
Any changes going through your mind?
Well, I think I'm quite fortunate for us because we've already taken out loans. The limits don't apply. So I am lucky, essentially, but I think it's disappointing, especially because often we're in mentorship roles where we talk to undergrad students, people who are pre-med or considering medical school, and now this is something that they do need to consider in their future planning. Like, can you afford medical school is essentially a question, or are you willing to take out private loans if that's what you need to do? So I think it just complicates the decision that's already challenging to make when you're like in your 20s. Do you want to spend the next 10 years of your life going to school to become a doctor?
Right. Yeah, makes sense.
And speaking of the bigger picture, so the next class to be enrolled will be affected by these limits. They will become full-fledged licensed doctors in 8 to 10 years afterwards. So the effects of these changes may not be fully understood for a number of years, and by then it may be too late to fix this stuff. It's tough to know with something as big and complicated as this to know what's going to happen.
So Izzy, what's the plan that you have? What's the career path? What's your goal?
I don't know. Throughout the way, I've been learning like what classes I really like. But at the end of the day, it comes down to what do I like in a clinical setting. Classes might be one thing, but the clinical setting is going to be a completely different experience. And so I'm trying to go in with an open mind because I'm super stubborn. So if I came in with an idea, then even if I didn't like what I was doing, I would still pursue it. So an open mind is going to take me a long way.
That's probably true. And as testimony to the stubbornness, you came all the way from Atlanta, not just to be here, but to go to school. So it takes some level of of determination to do that. How about you, Reba? What's your ultimate goal here? Are you clear about what you want to do, or are you still open-minded here?
I would say it's clear as mud.
Okay.
I definitely have a strong interest in like family practice or internal medicine, which are, I consider them jack of all trade, master of none. But a lot of that providing care is preventative medicine and communicating with patients what we know from like the science side into bits that are digestible to a lay person. And I guess it's almost like a public health where we just want to see the communities we're in be more healthy. So I think that's where my like passions are in medicine, and I'm just not entirely sure where exactly I will be as far as like what residency program I'll select.
Yeah. Okay. So, Dr. Atkin, what do you expect from students like Reba and Izzy when they're in this program? What are you exposing them to in this path to help them make these decisions?
Yeah, I'd be curious to know their answers to those questions. So medical school is a lot. We have heard it likened to drinking from a fire hose on many occasions.
Yeah.
It is a lot, and I want to underscore, these are students who have to start planning for medical school in undergrad. They may have started planning in high school, and they are really giving up a more traditional 20s and 30s to work tirelessly, round the clock, round the year, to help people in the future. And that's a big sacrifice. And I have all the gratitude in the world for students who are willing to do that. When they come to medical school, they're going to learn about all the systems of the body. They're going to learn about the nervous system from me, and cardiology and respiratory and all that stuff. And then they go into what's called clerkship, which is their third and fourth year where they're in hospitals doing things. During that first 2 years, I really emphasize to students, and they've heard me say this a million times, that one of the best things they can do is to get out of the classroom and go into the communities they hope to serve and learn about the lived experiences of those folks who are dealing with these conditions they're learning about. I'm going to make them memorize a bunch of stupid charts in class, complex, awful stuff. But if you can go into the community and see, oh, that's what that disease looks like, that's why we got to spend the time memorizing the stupid charts that Dr. Atkin wants us to, it makes it make more sense. And I also think it prepares them to be better physicians. The two students who are on either side of me here are also part of a program at MSU called Spartan Street Medicine that provides free medical care to people experiencing homelessness. And so they're really learning firsthand about barriers to health, what prevents people from being able to access health care, and how do we work around those barriers to try to keep people as healthy as possible. So I think that kind of work is really important. I'm touched that they have come with me here today. This is another thing that I'm really, an opportunity I'm grateful to be able to offer them, because I think asking someone to sit down and explain things to the sorts of folks they're going to see as patients is really valuable. I'm sure we've all had experiences where you're in a doctor's office and a doctor tries to tell you something and you have no idea what they're saying, and they seem incapable of communicating to you in a way you can understand, and you leave anxious and you end up Googling the thing, and that stresses you out more.
Right.
So we hope to change that by asking them to say it's not just enough to know the material, you have to be able to communicate that material.
So Reba, the process of becoming acquainted with dementia and memory care and that sort of thing, what kind of impressions has that made on you, and what has it meant for maybe what you might choose to do later?
I think I would say it has been very complicated. Arguably, the brain is one of the most complicated organs we study, the brain, nervous tissue in general. So I think sometimes we still struggle to understand, like in the scientific community, what a healthy brain does. So then when you introduce what an unhealthy brain is doing, that's even more complicated. And then on top of that, now you're trying to heal the brain. So all of those things have additional layers of like complexity. So learning it already is challenging because there are gaps. So as we continue our careers, we're going to fill in those gaps a little bit or even alter our understanding. So we have to keep an open mind to where science might go, especially for like neurology and dementia. So in some sense, it's hopeful because when we learn this, obviously we learn there isn't currently a cure, but hopefully research continues, so we might one day get a cure. And we're looking obviously at the genetic factors, the lifestyle risk factors. So we look at it from many points of view. And then also, as Dr. Atkin mentioned, looking at it from a patient's point of view or the caregiver's point of view when they receive a diagnosis of dementia, how to them they don't really care where the research is at that point. Like, they want to know what they can do with their life and what that's going to look like for them. So I think it's a lot of integrating all the information we currently have and then trying to communicate that to people, which is challenging when our current understanding as medical students is so fresh. Like, we just learned this material a year or two ago, and then trying to process that and then communicate it. It takes a lot of practice, so it's nice to have peers and educators who are so supportive.
How about you, Izzy? What do you think?
Well, one of the main reasons that I came into medicine was to be able to communicate not with just the patients, but with their families. And that's like from personal experience, where sometimes I felt like I didn't know what was happening in loved ones' health journeys, but other times I did. And those are the doctors that I aspired to be. And so being able to incorporate that into my medical education is amazing. And it was not really like what I had intended on getting to do so early on. But I'm absolutely thrilled to be able to practice it. And I think it's really important.
You know, Reba, you mentioned the notion of a cure, and Dr. Atkin and I were talking about this the last time we had a call, and the notion was, this is what people want to know, don't they? They say, are we close? Are we going to have a cure? Are we going to at least have a breakthrough sometime soon? And you had an interesting response to that, and maybe you can expand on that. Really, we're closer to prevention than we are to a cure. Talk a little about that.
I will credit Sherry Sherman with coming up with that phrase, but yeah, I think, you know, we have made significant advances in understanding what can help prevent or slow the onset of dementia. And when you think about folks who are getting this in their 7th, 8th decade of life, we have to weigh what are we trying to preserve, and if we can't cure dementia, can we at least slow the progression enough so that folks can still remember their grandkids and have good times and that sort of stuff. And it's interesting how many of the things that have been identified to help brain health are also the things that help heart health and other body health and those sorts of things. And the more active we can be engaging with those things, the better off we will be altogether. And that can even go so far as to prevent other maladies that are related to these diseases but not directly part of them. The example I'll use is that of falls. So falls are extremely dangerous, especially for someone in advanced age. And we wouldn't necessarily think of falls as being a major feature of Alzheimer's disease, but that can happen. And so keeping someone physically fit may not change, it's not going to reverse dementia, but may keep them out of the hospital so that they're not exposed to C. diff and other things that might give them infections and that sort of thing. Really to keep them where they want to be, which is home with their families.
Yeah. Well, that's an interesting point. And really, it's been enlightening this year as we focused on the Lancet Commission list of factors which can have an effect on, I hate to say preventing it, but at least reducing our risk, right? And when you look at a number of these different things, what comes up? But movement and exercise and things of this nature. However, I had not really given thought to the notion that you just expanded on, which is if you just keep your overall health at a certain level, this can keep you out of trouble in other ways. Yeah. The other thing that comes up, I think a fair amount is that folks want to know the easiest way to determine if they're predisposed somehow, right, to dementia. And one of them is the blood test question. Talk a little about that. Are we going to get there? I mean, is that part of what's been worked on in terms of diagnosing?
Oh, yeah.
It has.
So this is a complicated question. It is very reasonable that folks want to know, why can't I get a test that just tells me whether I have Alzheimer's or whether I'm going to get Alzheimer's? And part of that is that we don't really understand the disease process or what predisposes. We have some ideas. There's certainly some things that are more likely than others. And some of these are things you can get tested for. So you could get a genetic test looking to see whether you have 2 copies of a gene called ApoE4. You may have talked about this in your program before. ApoE, the ApoE proteins, their job is to clear out amyloid from the brain. And we know that more amyloid seems to contribute to Alzheimer's disease.
Right.
The ApoE4 protein, there's different versions of this protein, is the worst at its job. And so if you have 2 copies of ApoE4, you are more likely to have Alzheimer's disease and a host of other things. So you can get tested for that, but it's not a guarantee that just because you have 2 copies, you're going to get Alzheimer's disease. The other new development, which I have been asked about a lot, is a blood test for Alzheimer's. Can you go to the doctor and get tested and find out if you have Alzheimer's? The short answer is it can provide one piece of a complicated puzzle. The longer answer, let's get into. So let's talk about how Alzheimer's is diagnosed, or more specifically, the guidelines by which dementia is recommended to be diagnosed. And I want to be clear that none of us here are licensed medical professionals, so this is not medical advice, but just talking about what's out there. Historically, Alzheimer's, we've been somewhat limited in our ability to see what's going on in the brain. So a diagnosis of Alzheimer's was historically a most probable diagnosis based on symptoms, and then confirming that with looking at the brain tissue after the person has passed away. Nowadays, we have more advanced tools that allow us to see what's going on with the brain. So ideally, the first thing that's going to happen when you go into a doctor's office and you're worried about dementia is they're going to screen out anything that can create a dementia-like presentation that isn't dementia. These are things like medication side effect, sleep apnea, depression, vitamin deficiency, all those sorts of things.
Sure.
Then they're going to get a really good sense of your symptoms. They're going to give you a host of neurologic function tests. There's a bunch of these different ones, and they sometimes ask you, can you draw 2 intersecting pentagons? Can you draw a clock that shows this time? Can you remember these words? All that sort of stuff, which allows the specialist to really get a better handle on what is your cognition like. If there is concern, they're then going to want to see, has the structure of your brain changed? And for that, you're going to get an MRI to see are there changes in the structure. But the other tool they can use is something called PET scanning. So PET scanning, it functions not unlike an MRI, but it uses some radiation to see what's going on in your brain with particular proteins, specifically amyloid and tau, the 2 that we think of associated with Alzheimer's disease. So we can go in and say, how much amyloid do you have in your brain? How much tau do you have accumulated in your brain? And often there's a ratio that's formed, and then that is one part that we say, okay, we've got all these clues now. We've got the clue that it wasn't sleep apnea. We've got the clue that you have these symptoms. We've got the clue that your brain is changing shape, and we've got the clue that you've got these PET results. It's pretty likely that this is the diagnosis.
And those are a lot of steps.
A lot of steps.
That all come together for some kind of conclusion.
Right.
And clearly that's more than a blood draw.
Right. The question is, PET scanning can be difficult to access. Not every place can do PET scanning. It takes time. Some people are uncomfortable being put into a scanner like that. There's a bunch of reasons why that's an issue. So the question is, can you do a blood test that takes the place of that PET scanning? And that's what this blood test is intended to do. I will say there are many different blood tests. The one that was recently FDA approved, which is called Lumipulse, and they are looking at a blood test that tells you whether or not you'd likely have results on a PET scan that are consistent with Alzheimer's disease.
But we haven't started doing that yet, right?
Well, there have been trials, that's how it got FDA approved, that says, okay, if you look at the PET scans of these patients and you look at their blood test results, do they match or don't they? It's worth bringing up 2 other terms here for folks to understand as we talk about tests going forward, and that's specificity and sensitivity. Sensitivity is if you had 100 people who had the disease, how many of those people would your test identify as having the disease? So you have 100 people who have Alzheimer's disease, this test is going to detect how many of them. For this Lumipulse, it's 92. So 92 of those 100 people, the test is going to say, yes, this person has Alzheimer's, or has pathology that's consistent with Alzheimer's disease. Specificity means if you had 100 people who did not have Alzheimer's disease, how many of those people is the test going to say they don't have Alzheimer's disease? So how accurate are your negatives?
Yes, so this is the challenge with it.
Yeah.
You can't just start taking blood and getting
Right.
results.
Absolutely.
You have to go through this process.
And part of the concern too is who's doing the test. Ideally, you want to see a dementia specialist. Short of that, you want to see a neurologist who's trained to do these things. This test means other folks could do the test conceivably, and I have tremendous respect for other fields, but I think because it's one piece of a very complex puzzle, you want somebody who spends a lot of time working on that puzzle. And the risk is you get a result from this test and you hang everything on that test and it's not 100%.
Right.
That's the take home. These tests are one piece, one clue to a puzzle, but it's not the be all end all.
Well, maybe the next time we talk, there'll be some information
Who
this
knows?
way that will have gone further than we have today. But boy, are we glad we had this chance for all of you to be here, and we thank you for that. And of course, Dr. Etkin, we thank you for all the information that you bring us.
Anytime.
Miles for Memories as well. Thanks to all of you. Good luck.
Thank you.
And we appreciate all your insights. Thanks. We're going to continue with creating dementia solutions this year, focusing on that Lancet Commission list of factors over which you have some control that could mitigate your risk of dementia and Alzheimer's. And again, click the like button on the Miles for Memories page on Facebook so that you're alerted when these episodes come available. Richard Pyatt here. Take care.